The health and medical information provided during this webinar, as well as the questions and responses from the webinar providers, are solely for informational purposes. This content is not intended to take the place of advice or treatment from health professionals. Nothing presented in the webinar is intended to be used for medical evaluation, diagnosis, or treatment. It is not intended to substitute for your relationships with your own healthcare and pharmaceutical providers. Always seek the advice of your healthcare provider before beginning any new treatment, or if you have questions regarding a medical condition.
I'm Dr. Roger Khouri. I work with Northwell Urology. I'm based out of Long Island. You can see where I've trained and what I specialize in. Okay, so we'll talk about the erection process. So this is just showing you the normal anatomy here. On the left, this top left picture is a flaccid penis in cross section, where if you took a penis and you cut it and looked at it under the microscope, you'd see this bottom part by the floor is where the urine comes. That's the urethra, and then these larger circles at the top are called the corpora cavernosa, or the erectile bodies. Those are the parts that fill up with blood during an erection. And you see these tiny arteries sticking out, one on each side. Those are the arteries that deliver blood to the tissue. And when it's time to get an erection, the nerves send the signal to the arteries to open up. The arteries open up, and then you move to the top right screen here, where you have all this excess blood tissue filling the corpora cavernosa, and that spongy tissue fills up, and that gets the erection that you want. And then when the erection gets full, it also tightens on the veins, which are the blue, so that you don't have a leak, so the blood doesn't leak out during the erection. Okay, so there's plenty of options for erectile dysfunction. Obviously, talk with your urologist about which one is right for you. But today we're going to just focus on one, which is the intracavernosal injection therapy, or ICI, or just penile injections. And it's intracavernosal because it goes into the corpora cavernosum, which are those erectile bodies that fill up with blood. So how do ED medications work? As we talked about, it basically increases the blood flow to the penis to achieve and maintain an erection strong enough for sex. Usually the pills, obviously like Viagra, Cialis, you take those and they'll open up the blood vessels, but they open up the blood vessels somewhere else in the body too, so you have risk of overdose and side effects. We have much less of that issue when we're delivering the medication directly to the penis. So we can deliver much stronger concentrations, doses of medication to the penis without worrying about headaches, flushing, or your blood pressure dropping. So all of these medications, if you didn't go to med school, they're basically all medications that work to dilate the blood vessels by different mechanisms of action. And when you get your vial with the medication in it, it's typically a mixture of 1, 2, 3, or all 4 of these medications. So the bimix is a mixture of 2 of them, papaverine and phentolamine. Trimix is 3, and quadmix is 4. So you can't just like go to a store and pick up Trimix. It has to come from a compounding pharmacy where each of these drugs are put into the solution, and that's the medication that you're delivering to the corpora cavernosum for the intracavernosal injection. Okay, so this is kind of specifics that you'll have to talk with your physician about, the ordering provider. The MD obviously can't order the medication for you. They're just take the order and make the medication and send it to you. So all along the list here, you see the different concentrations of bimix, trimix. They even have an alternative, low alprostadil trimix, where the ratios are somewhat different, and then quadmix at the bottom. These numbers here, like at the top where you see bimix number 3, that's sort of an internal pharmacy thing that MD does. The doctor just puts in their order, and then it just makes it easier for the pharmacy to say, okay, I'm taking bimix number 3, and they'll give you a certain volume of that concentration of drug. Usually people start with the trimix, but that'll be a discussion between you and your doctor. Alprostadil, it can cause some side effects, aching sensation in the penis. So sometimes that's why they have the lower prostadil trimix with different ratio. Um, and then same thing with quad mix, there's different ratios. Okay, needle size and dose volume. So needle and syringe, the medication injected into the penis is a very small needle. The needle sizes in general can vary in two ways, the gauge, which is the thickness of the needle, and the length, obviously how long the needle is. And generally speaking, we're going to be using the smallest types of needles possible. So when people talk about pain with injection, there really should be almost no pain because these needles are so small. It's mainly a psychological thing, and I'll show you in the example here. You'll see the needle, and then same thing. The syringe is the plastic part that actually draws up and delivers the medication. There's obviously different size syringes, but the ones that you'll typically use have a maximum volume of 0.5 cc's. A cc and an ml are the same thing. So you're talking very low volumes as well. And the syringe and the needle will be part of the prescription from the doctor. So that has to come in too, and then MD gives you what the doctor ordered. And then the dose volume is just how much of the fluid you're getting. And depending on the concentration and the volume, that's how much of the drug you get. Okay, so starting dose, adjust, log precedent. So basically, this all comes down to you and your physician deciding on a starting dose. Obviously, they're going to want to do a relatively lower starting dose, the safe dose, so that you don't have what's called a priapism, an erection that lasts longer than 4 hours. And then they can titrate up or increase the dose as needed. And the first injection is typically done in the office, so the doctor can make sure that you're doing it right and that you have the appropriate response. So adjusting the dose if needed, that's obviously going to be a discussion with you and the doctor. So this is basically just on the top right, the rigidity scale from 0 to 10. 0 is obviously completely flaccid, and 10 is max. The goal is this 7 to 9 range. That's sort of what most men have during an erection. There's nothing per se that's wrong with getting to 10, but when you're talking about doing the injections, we worry that people are giving themselves too high of a dose. We typically, as urologists, tend to see problems around Valentine's Day or maybe on your wife's birthday or something, where somebody decides to give themselves 5 times the usual dose of the medication, and then they show up in the emergency room with an erection that won't go down, and it's a bad situation. But if you're using the dose that the doctor prescribed for you and you're using it appropriately, this issue of priapism or an erection lasting longer than 4 hours is almost unheard of. So it's very important that you're talking with your doctor and you're staying in this target range. Full erection that doesn't come down means it's too long. Do not exceed the maximum dose. You only can do 1 injection in a 24-hour period and only 3 to 4 times per week. Okay, preparing for the injection. The first thing you need is your drug. This is just a vial of water, basically, but it's your medication that comes in this small cylinder. It typically comes in about this volume, about 5 cc's. We'll talk more about this when we do the model. You need your syringe, which is just what it sounds like, something to draw up a fluid. It usually comes with a needle that's right on the top of the syringe. I don't know if you can see that well there. And then that's about it. Can move on. The alcohol prep pads are just what it sounds like to keep the area clean. So in terms of steps, and I'll demonstrate this in a minute, to prepare the syringe, obviously you remove the cap that's protecting the needle, and then you basically get the syringe ready. So you load it back to the dose that you're supposed to be using. Typically it'll be like 0.4 cc's, and then you're going to put the needle into the vial, and then you're going to turn the vial upside down so that the air goes to the top, and then you're going to basically fill the syringe with the medication, just aspirating back, and then you push out any of the bubbles, and then your dose is ready. And I'll demonstrate this here in a second. Okay, and then in terms of the injection itself, first you're going to swab the area with the alcohol prep pad, just what it sounds like, allow it to dry naturally, and then you're going to insert the needle. So in terms of location, this is again showing on the right side of the screen the cross section of the penis with the urethra at the bottom, and on the top is where all of the nerves and blood vessels are. So those are the spots that you want to avoid at all costs. So you basically want to come in on the side, and you can cheat up a little bit. So it says 1 to 3 o'clock, but anything even 3 o'clock even is fine. The main thing you want to avoid on the bottom side is the urethra, which is pretty easy to avoid. So once you've picked your spot and you've cleaned it, you're going to put the needle into that spot on the side of the penis, and then pick a spot where there's no veins, and then push the plunger in to inject the medication. Okay, take the needle out and then hold some pressure on there for a couple of minutes so that the little needle puncture site doesn't bleed, and by then the medicine should be kicked in. So side effect mitigation, obviously using proper technique. The first dose is done in the office. Obviously, make sure you're talking with your urologist to get the proper dose concentration. Don't always use the same site. So that you can go anywhere up and down the shaft of the penis as long as you're not injecting it into the head of the penis. And then again, only once in 24 hours. In terms of storage, when you have your vial, you want to keep it refrigerated, and the total shelf life of a refrigerated vial is 60 days. Now, that can be a little bit less if you puncture it early. So let's say you puncture it on the first day, then the vial will only last for 30 days. So it's only 30 days from the time that you first puncture it, or 60 days in total, whichever one comes first. Obviously, if you puncture it on day 50, it's going to sort of go bad by day 60. Now, it doesn't actually go bad. It's not like you're going to get sick if you inject yourself with a vial that's 70 days old, but the medication may be a little bit less active, a little bit less effective. Okay, accessories help. We can talk about that. So the insole tote is basically just a tote bag. I've got an example here that I can show. It's nothing really out of this world. Basically, I'll show it more when we're on the full screen. Just what it sounds like. It's a tote bag that has the places to hold the syringes and the medications, and then it has on the inside sleeve here one of those ice pack type of things, so it can keep your medication cold. If you're going on vacation or something, this will stay cold enough, likely for your travel time. This Insole Ease auto injector is basically really for men that have issues with dexterity, that they wouldn't be able to use the syringe. Otherwise, I think it makes it more complicated than needed. And then the sharps container to dispose of your sharps properly. It comes with one of these little rectangular things. You shouldn't be just throwing needles, especially used needles, in the trash can. That's a biohazard. Okay, and then obviously for more information, you can talk with your doctor, but you can look on some of the information that's available on MenMD on their website, or you can also call for help as well. All right. Everyone can still hear and see me. I'm going to turn my camera down a little bit so you can see the demonstration. It should be really straightforward. It should be really simple here. Basically, you just need the three things: your drug, your syringe with the needle, and your penis. So first thing with the needle, you're going to take off this orange thing. This one is protecting the plunger, and this one is protecting the needle. I want you to see how small this needle is, relative to my finger. I've got pretty big fingers, so this is a tiny needle that really should not hurt. And then you take your medication, okay, and you want to hold it upside down so that the air goes to the top. Now, sometimes these vials come with a little metal seal over it that you just have to pop off. So then now you're looking at the metal with the rubber in the middle that you can puncture. And basically, what they'll recommend is that you load up your syringe with air to the dose that you want. Let's say it's 40 units or 0.4 cc's, and you'll basically puncture that little rubber spot. You can push some air into the vial. You don't really need to do that step, but it can just help make the aspiration a little bit easier. And then you just aspirate back. You can't really see clearly on this video, but some of the fluid from the vial is going into my syringe. Once I got the dose that I want, I'll just basically flick it to get some of the air out. Okay, you can then take it out. Now this vial doesn't leak when you take it out. You're done with this. I'll flick this to get any more air out. Might push it a little bit to get any last little air drops out. Okay, now I've got my dose that I want. And now here's the penis. So again, the urethra runs at the bottom and the nerves and blood vessels run along the top. So you're going to want to come along the side. You can cheat up a little bit towards the top. So the recommendation is between 1 and 3 o'clock. And you can do it anywhere along the shaft on either side of the penis. You only have to inject one side. Those two corpora cavernosa are connected. You don't need to inject both sides. So you'll pick your spot, you'll clean it up, you'll let the medication dry, and then you'll basically put the needle into the side of the penis. Okay, you'll deliver the medication, just pushing the syringe here. Okay, you take the syringe out and you hold pressure. And this stuff works automatically. It's not like the Viagra where you need to have some sort of stimulation, to get the process going. You could be sitting here talking politics. If I inject your penis with this medication, it should go up. So it's very easy and straightforward. There's not a whole lot to it. We can demonstrate that again. Again, you take your needle, you puncture the vial with the medication. You can aspirate the dose that you want. Okay, let's say we're going to do 30 cc's here. Okay, disconnect. Get your air bubbles to go to the top of your syringe. Push the air out. Okay, take your medication, put it into the side here. Oh, your penis you cleaned it with the alcohol swab. You pick your area between 1 and 3 o'clock, where 12 o'clock is the top and 6 o'clock is the bottom. So just kind of along the side, push the needle all the way in, and then just push the medication in. Take the needle out, hold pressure for a minute or two, and you're done. So I don't know what else to talk about. Oh, I guess disposing. You don't need to recap your needle. Just throw it into your needle container, and that should be it. You put your medication back in the fridge, and just mark when you first punctured it. You got 28 days from then, or 60 days from when you first got the medication to use it. I'll open it up to questions if I missed anything.
All righty. Going to start with some general ED questions, I guess, before we get into some other injection therapy ones. But this one's injection therapy related. This person wants to know what happens when a man becomes weary of self-injecting. Any tips to overcome the fear?
It depends. If you're saying weary like you've never tried it before versus weary you've tried it and you really don't like it. A lot of men, come to me because the Viagra stopped working, and I talk with them about the options. Some of them, as soon as I mention this, they say, okay, next option. I don't want to hear any more about that. And I think it's just psychological, the idea of putting a needle into your penis and having to do that every time you want to have sex. That's the hardest part. The actual pain of it, I do have some patients that complain about it, but most people don't. So I'd say if you're sort of nervous about trying it, I would recommend giving it a try in the office with a doctor. And if it's horrible experience, you never want to do it again, then just don't do it again. But if you tried it and it doesn't seem that bad, then I would give it a give it a try to use it in real life. Because if this doesn't work, there's vacuum devices and other things, but the next option is the penile implant, typically the inflatable penile implant, and I do those surgeries. We can talk more about that, but I typically have people at least consider this before moving on to that.
Alrighty. Next question here is to be our last general ED question before we go all injection therapy. But this person says, how common are ED problems to develop in a healthy male who is a non-smoker, non-drinker, with a healthy diet? And this happened to begin in his late 30s.
Late 30s, I would say, is uncommon to have severe ED, especially ED that doesn't respond to medications. I think most guys in their late 30s might say their erections aren't quite as strong as they were when they were 20 years old. Some of them might get some benefit from the Viagra, Cialis, but it's pretty rare for someone in their late 30s who has no other medical history to develop severe ED. As you get older, like by the time you're 50 years old, probably 50% of men have some degree of ED. Now, some of them, it may be mild, they may take some Viagra and they're good to go. Some of them more severe. So definitely the probability increases with age, even if you're perfectly healthy. But if you're in your late 30s, I'd be surprised if you're that healthy and the pills aren't working. It's certainly possible. And if that's the case, then definitely see your urologist and consider the other options.
Alrighty, we're going to hop into those injection therapy questions now. So first question here is, are the corpora cavernosa bodies interconnected? That is, does an injection on one side of the penis diffuse somehow to the other side as well?
Yes. The corpora cavernosa are fenestrated. So those two cylinders, they sort of share a wall, and that wall basically has holes in it. So yeah, you don't have to inject the medication on both sides. The medication goes to both sides, and that's true for anything. If somebody comes in with a priapism, an erection that's been up for days, and I want to inject the antidote, I don't have to inject it on both sides. Just inject it on one side. It goes to both.
Alrighty. Next question here. How do you end an erection after intercourse? Mine frequently last well beyond ejaculation, which can be inconvenient and embarrassing.
Interesting. I'm assuming that's a patient who's already been on the ICI. Most men don't have that issue after a regular intercourse. If that's happening after the ICI, you can try like exercise. Basically it's an issue of blood flow. So if you start doing some type of physically demanding exercise that requires blood to go elsewhere, it should shunt away from the penis. Ice packs can work. You can try actually masturbating and ejaculating again. All of those things will help bring the erection down. Obviously, if it's staying up after 4 hours, you got to go to the emergency room, and that's not just like doctor giving some warnings. That's pretty serious. We've seen people who wait a day or two, and then you have some serious long-term side effects of that.
Next question here. What is the cause of inconsistent results in the length of time the erection lasts while using the same dose of ICI medication?
Not totally sure. There's a lot of variables involved with an erection. Part of it can have to do with the nervous system, or basically your psychological component. So an erection is part of this. The nerves that control erections are not the same as the nerves that say control your hands, right? You can't just tell your penis to go up. It's part of this automatic nervous system. So the automatic nervous system basically has two components, the fight or flight component and the rest and digest component. And an erection actually is under the rest and digest component, which makes sense because if 1,000 years ago your ancestors saw a bear, that's not the time to get an erection. So your brain is wired so anytime there's any sense of fear, anxiety, stress, shut down the erection and get the blood elsewhere. And sometimes we see that in men with their sexual encounters. They're nervous that they're not going to perform well. Maybe there's some relationship stress, performance anxiety, work stress. Any of these factors play a role. The penis isn't just a bag that fills with blood. It's connected to the nerves that go to your brain. So if you're really anxious about whether or not you're going to perform, whether you realize it or not, that's going to affect the quality of the erections. And some things are just, some days you can lift more weights than on other days. Your body's just not the same every day. A marathon runner doesn't always run the same time. Some days they perform better than others. So if you're having that issue that it's not lasting consistently, you might need to increase the dose. The other option is the penile rings that go along the base of the penis to help keep the blood in there. And part of it is sort of understanding the psychological component and trying to get rid of any stress or anxiety that you have about performance.
Alrighty. Next question here. Can a person who has failed penile implant twice use injection therapy?
Not really. When you say failed a penile implant, that means that the implant was since removed. So then in that setting, the injections are likely not going to work because the penile implants, and we can do a separate talk about that later, basically go inside of the corpora cavernosum, and when they fill with the saline, they basically crush the natural spongy tissue that fills up with blood. So when you take one out, the expectation is that you're not going to be able to get a natural erection again. And that's part of the reason why we try to get people to try the injections before going to the implant, because obviously you can go from injection to implant, but you can't really go from implant to injection. So if you've had the implants before and they haven't worked, you likely need another implant to be able to have an erection again. And you might not need to go to just your average urologist. You probably need to go to a reconstructive urologist or somebody who's experienced with these revision cases, because average urologist might do a couple implants per year, but there's some of us that do multiple of them in a week. So you want to go to somebody with more experience for one of these complex cases. One disclaimer that I'll have to mention is I heard a story, I never saw this patient, of somebody who had a penile implant in and it was working, and on Valentine's Day or something, he wanted a little extra push, so he gave himself an injection, and without realizing it, made a small hole in his implant. And interestingly, it didn't present right away. It took several weeks before the implant sort of ran out of fluid. So don't do that. If you have an implant, you can't use the injections.
Alrighty. Next question here. Typically, how long should it take to get an erection after using the injections?
Couple minutes. It's pretty much automatic. It's not like the Viagra where you got to wait for it to kick in and still do the normal sexual stimulation stuff. It's automatic. We do them in the office, talking with the patient. The erection comes up within a minute or two. So there's no real wait time.
Alrighty. Next question here. Is it better to increase the strength of the formulation rather than increasing the volume of a lower strength formula?
That's a good question. On paper, obviously, it doesn't matter. It's just the total dose of the medication. And so it's really just up to you. Generally, I would say it's probably easier to increase the volume if you don't have any issues with injecting, just because it's a lot safer. You get a more precise dose, right? If I have let's say I'm doing 25 units here, and I want to increase it. I can just, draw up more medication little by little. But if I have a stronger medication, then any sort of error in how much I draw up gets amplified. Um, and these are such low volumes, even the most we have you put in at once is 1 milliliter or 1 cc, which is not a high enough volume that you're going to feel any different from the volume itself. I would say generally I would go with increasing the volume first.
Alrighty. Next question here. Once the dosage slash formulation is determined that you're going to start with, do you provide, and you get a prescription, I guess, from a patient's point of view, does this require any ongoing clinic involvement?
Yeah, most clinics are going to want to have some type of follow-up. I mean, even if it's just a telephone visit before refilling the medication, and that could be really, really quick. Just, hey, this is working. I'm super happy. Can I get a refill? And once you're happy and you're everything is working well, you can probably ask to get more refills at once. But we generally don't have people just come in one time and never talk to us again and use the injections for life. It's not that we're trying to bill you for a clinic visit. We just want to touch base and make sure that everything is going well.
All right, certainly. Next question here, kind of along the similar lines. Must you see a doctor before you restart injection therapy after stopping it?
Probably. If you're going to see a new doctor, like if I've never met you before and you told me, I did this in the past and this was my dose, I would want to at least see you once in the office and before ordering the medication. That's pretty universal. Generally, the new patient visits are in person. I guess there's probably some places around the country where they have urologists doing entirely virtual clinics, but it gets a little dicey with different state lines and things like that. And we generally want to be treating patients who are close to us. So if there's a problem, they come to our emergency room, not somewhere on the other side of the country. But yeah, it's not that bad. Just come in for a quick 20-minute consult, and we'll get you back where you were.
So this next question here is just about quad mix, I guess. So you could just talk about, I guess, what the addition of atropine does into that mix.
It's basically just another medication that helps to open up the blood vessels. So if you're sort of maxed out on the other three, and you're really trying to avoid going to a penile implant, then we throw in basically a fourth medication, and we can titrate up the doses as well on that. So it's just another option to give you more of the medication essentially in a safe way.
Alrighty. Next question here is just asking to compare ICI injections versus intraurethral gel with respect to their effectiveness and risks.
Mm-hmm. I can say I don't have any patients that are using the intraurethral treatment. From what I've read, the ICI should be more effective, fewer side effects. The intraurethral gel or pill, from what I've read, it causes quite a lot of pain and burning. And also there's neither of them really are very high risk in terms of something that's going to get you sick or in the emergency room. It's more just at what point do you develop pain or other symptoms versus the effect of getting the erection. So either one is fine. They're both on the official urology guidelines as an option, as well as the vacuum erection device with the penile ring. Those are all sort of in the same tier between the pills and the implant. So all of them are totally safe. Actually, the vacuum is probably the safest because there's no drugs involved. But between the injections and the intraurethral suppositories, it's just a matter of the side effects. So you can try try a low dose of the intrauterine suppository and see if that works. But I generally don't even bring it up with patients because people, from what I've read, don't tend to like it.
Alrighty. Next question here. Will injection therapy help with my venous leakage problem?
On paper, no. On paper, if the problem is a venous leak, these medications only work to increase the blood supply. Now, it gets a little bit complicated because the only way that you sort of know that you have a venous leak, generally speaking, is to do the injections and then do what's called a Doppler ultrasound, basically an ultrasound of the penis after the injection has been given. But if you've already given the injection, then you can just ask yourself if it worked or not. And there's not really that much benefit to the ultrasound. So you got the injection and you didn't get an erection, then the injection didn't work. And you can try increasing the dose, but you sort of have your answer. So it's a little bit more this whole distinction between whether you have a venous leak or arterial insufficiency is somewhat academic. Basically, if the injection's not working, even at the max dose, then the only option left is a penile implant, and that will work whether there's a venous leak or arterial insufficiency. The only thing that's thought to maybe help with the venous leak would be the penile ring that goes around the base of the penis, but that's not that effective.
Alrighty. And a little bit of a follow-up to that, is there any specific blood vessel or valve that is responsible for the leakage in terms of addressing this, or is it just a general blood flow problem?
It's just a general blood flow problem. There's no like one specific venous valve that is leaking. There's hundreds of veins throughout the penis, and there's no real way to fix this. There's no vein surgery for this. So the natural sort of valve that we have in the penis is the arteries filling up with blood and sort of squeezing off the veins. So in theory, increasing the arterial blood supply with the injections should help with that. And the penile ring also helps with that. But no, we don't have any specific therapies designed to address the venous leak. And I don't almost never, I won't say never because I have done some, do a penile ultrasound in the office to diagnose a venous leak.
Alrighty. Next question here. Can the ICI treatment cause penis shrinkage?
It shouldn't. Most men don't complain about that, but it is possible. So in men who have Peyronie's disease, which is where they basically develop curvature of the penis because of scar tissue, I typically don't recommend the ICI injections because they're prone to forming this scar tissue from micro trauma. So you've probably seen those commercials of the bent carrot. That's the Peyronie's disease. So in theory, even if you don't have Peyronie's disease and you start doing a lot of ICI, in theory you could develop Peyronie's disease from the injections, and that could cause curvature or shrinkage. But 99% of men don't have that problem with the ICI, with the sort of note that we generally don't start people on ICI if they already have a history of Peyronie's disease.
Alrighty. Next question here. I'm curious about what components of Trimix are most likely to cause a priapism.
It's all of them. So all of these medications basically work on the blood vessels in the penis to cause them to dilate. So there's no one component or the other. It's just the overall dose. And just want to reiterate, the risk of developing a priapism from ICI is very, very low if it's done in the proper setting. I've never actually seen it. Every time, I've dealt with a lot of priapism between residency and in practice. It's always somebody who injected themselves with more dose, or they took some other drug, or they have some other medical condition that caused it. And in terms of priapism, just while we're on the subject, if somebody does come in and the erection has only been up for 4 hours or so, we can basically we have an antidote that will make it go down right away, and it's not that big of a deal. There's no long-term consequences of that. The problem is a lot of guys don't want to come in to the ER because they're embarrassed or whatever. They wait a day or two, and that's when it's a real problem. It's hard to get it down, no pun intended, and it is going to have some long-term side effects. So I wouldn't worry too much about priapism if you're doing the ICI the recommended way. It shouldn't happen, and if it does happen, if you come in right away, we can get it fixed.
Alrighty. Next question here, does alcohol affect the effectiveness of penile injections?
Low dose, if you're having a beer or two or a glass of wine or two, it's not going to be an issue. If you're getting like totally trashed, then you might not be able to get an erection. That's whiskey dick is real. But if you're that drunk, you're probably not even going to be handling the needle appropriately. And some people actually note some benefit to having a drink or two because it can sort of relax your brain a little bit and deal with some of that automatic nervous system stuff that we talked about. People having anxiety and stress, and that causing them to lose their erections. So it's not a contraindication. You can have a drink or two and still do the injections, and it's not going to affect it in terms of the efficacy unless you're really pounding back drinks aggressively.
Alrighty. Next list of questions is going to be some injection technique questions. So first one here, this person needs better guidance on their location. They have foreskin, and they want to know if they need to pull it back before the injection.
No, you don't need to pull the foreskin back because the foreskin just goes over the head of the penis or the glans penis. You don't want to put any needles in here. This is a separate anatomic structure than the corpora cavernosa. So that shouldn't be an issue. You can have foreskin going over the penis, and you can put the needle through your penile skin just like a circumcised man would, and that won't be an issue.
Alrighty. Next question here. This person says they have problems with the needles bending, and they want to know if there's any device that can prevent this.
Needles bending. I haven't heard that one before. I suspect that this thing might help. This what is this called? The Inject Ease. It's a product that MenMD sells that helps make it a little bit easier to inject. But if you're injecting the needle head on, you're coming in at a perpendicular angle to the skin, it shouldn't really bend. Maybe torquing it a little bit, and that might be causing slight bending. I want to talk with this person a little bit more to see, how bent we're really talking. Are they using a tiny needle like this? Because it'd be pretty hard to bend this. I'll try it. This guy. Yeah, I mean, this tiny needle, doesn't have a lot of length to it, so there's not a lot of torque to bend on. And this penis, which is actually somewhat structurally similar to a usual flaccid penis, I'm not able to get it to bend. So you maybe, it actually just sort of tears through the penis. You maybe need to adjust your needle would be my guess. You want to have a short needle would probably be the key, and making sure that you're going in, perpendicular to the skin, right there. And then it really shouldn't bend. But if you're having that issue, I don't know if you live near Long Island, if that's something you want to talk with me about, or talk with your urologist about, and they can sort of maybe do a dry run with you in the office to see what you're doing and see what's causing this.
Alrighty. I guess a follow-up to that question is it possible to bend the needle on the vial itself when they're maybe drawing up the medication? That is a question we have here.
Oh, let's see. So it shouldn't. Like when you put it in the vial, it just sort of goes right in at a 90-degree angle. I'm going to try it here. I've never done this before to bend it. Yeah, you can bend the needle, but I feel like that would have to be intentional. Yeah, and if that did happen to you, just throw that needle away and get another one. But it does, and you would be able to look at the needle before you put it in your penis. But if you rest, you don't need to be a microsurgeon to be able to put this in at a 90-degree angle. You can have somebody hold the vial for you even, and you just push it in. Well, this needle's already bent because I bent it. You just push it in, and there shouldn't be any issue with the needle bending. And if you need, reteaching, just go see your urologist and see what could be the issue. Yeah, this needle, once it's bent, it's hard to get it to be straight again. So I wouldn't mess around with bent needles. Just throw it out and get a fresh one.
Certainly. Alrighty. Next injection technique question here. This person wants to know if standing, if there's any benefit to this while injecting.
No, not unless it's like helping you in some way see what you're doing. But in terms of the blood flow, it doesn't really matter. Standing, sitting. I hear people say all sorts of different stuff. Oh, it only works if I'm standing, or it only works if I'm sitting or laying. There's no real explanation that I can have for why that would be. I would just say whatever is the easiest way for you to get the medication in yourself, do that.
Alrighty. Next question here. Is it common to have consistently better response to injection on one side of the penis or the other?
No, that's not common, but I suppose it's possible, especially if you have some type of Peyronie's disease or scar tissue on one side of the penis. The other side would likely work better. But in theory, it should be the same. Any medication you inject on one side should get to the other side within seconds. If that's the case, if you have one side that's good or one spot that's good, yeah, if you have one side that's good or one spot that's good, just use whatever side that is. But generally, it should be fine either way.
Alrighty. Next question here. How many hours must we wait between Trimix injection here?
Yeah, so 24 hours between injections, and generally not more than 3 or 4 times per week. But definitely wouldn't do it twice in a day.
Next question here is this person wants to know what the best way is to insert the needle when his belly keeps him from seeing down there.
That could be a little bit tricky. I'd say ideally if you have your partner help you. I understand that's not always possible. Probably laying down, your belly would sort of be out of the way as much as possible. But then it's going to be a lot of tactile, right? Just what we call proprioception in neurology. Basically feeling the penis, feeling the spot that you want to inject it, maybe pinch that spot, and then sort of just with the tactile feedback, be able to guide your needle to that spot. Most neurologically intact people should be able to do that, but it could be a little tricky. That would be my recommendation, is try to, pick the spot, maybe pinch that spot so your brain sort of recognizes that's where it is, and then sort of guide your needle to that spot. It would probably take some practice, but I think it wouldn't be that hard to do.
Also have some feedback in the chat from someone who is in a similar position. They say that they use their wall mirror to help them assist the process.
That's someone smarter than me. I didn't think of that. Yeah, that would work. A wall mirror would help you see what you're doing.
Alrighty, and just to move along to the next question, this came up a few times, but if there's any sort of injection site pain, what is the best way to avoid and/or relieve this?
Ice can help. Ibuprofen would probably be the best medication to help, but ibuprofen is going to take a while to kick in. Same with Tylenol can help. Ibuprofen would probably be better. The other option, I've never had to have a patient use this, but there's topical anesthetics, like I believe it's called EMLA cream. It's just a cream with lidocaine in it. I believe it's mainly used for patients with hemorrhoids, but it works well. Basically a cream that you could put on your penis to numb that site, so you have less pain there. Obviously, you don't want to numb your entire penis, otherwise you're not going to feel the sex. Some people actually do use topical anesthetics for sex to deal with premature ejaculation, but that's sort of a different topic.
Next question here. How do I stop bleeding at the injection site?
It's mainly going to be pressure. So I'm assuming you've already tried that, but you just hold more pressure, harder pressure and for longer, basically, will get the bleeding to stop. And what we see sometimes is, people hold pressure for 30 seconds, they get impatient and they check, and it's still bleeding. Hold pressure again for 30 seconds. I would say, hold the pressure as hard as you can and keep that pressure there, especially if you're somebody who has this problem. Maybe set a timer, like 5 minutes of hard pressure. I'd be surprised if that tiny needle spot is still bleeding if you don't have a bleeding disorder. This is, sort of off topic, but a common consult, that somebody has, bleeding from an incision and the ER can't get it to stop, and, send an intern down there and tell them hold pressure on that spot for 30 minutes and then call me if there's a problem, and they never call. So the problem is not holding pressure, one, either hard enough, or two, long enough. But it's a tiny needle, so there's no reason that should not clot if there's no bleeding disorder.
Going to move along to a new group of questions about injection therapy with other conditions. So this person wants to know if this procedure would work with BPH and which should be treated first, the ED or the BPH.
Yeah, the BPH is sort of an entirely different disease, and so it wouldn't have any effect one way or the other. I would say to treat them both simultaneously, just because they both can have a major effect on quality of life. But either order would work well. The only time, with BPH, the things that you need to think about in terms of sexual function, the most common medication used for BPH is tamsulosin or Flomax, and that shouldn't cause any issues with erections, but it does typically cause what's called retrograde ejaculation, meaning that when you have an orgasm, everything feels the same, but nothing really comes out, which is fine. It's not dangerous unless you're trying to have kids or something, but just something to be aware of. The other medication commonly used for BPH is finasteride, which works to shrink the prostate. Some men report that finasteride can decrease their libido and decrease their erections. Obviously, if you're having that, you might want to stop that medication, but most men don't have any side effects from finasteride. And then the other one that has some crossover is actually the Cialis, tadalafil. Low dose tadalafil, the 5 milligrams per day, is commonly used for erectile dysfunction, and it has been shown that actually helps men with their BPH symptoms. We don't really understand exactly why that is, maybe better blood flow to the prostate, but a lot of men take the Cialis 5 milligrams a day, and that helps with their ED and their BPH.
Next question here, does injection therapy affect high blood pressure and or someone that is on blood thinners?
So sort of separate questions. The blood thinners does not have any effect on the erections. The only potential issue is the bleeding from the injection site, but it is not a contraindication, meaning you can still do the injections if you are on blood thinners. You just need to hold pressure for a little harder and a little bit longer, and you are at a slightly higher risk of developing bruising or hematoma, something like that. In terms of the elevated blood pressure, you should make sure that that's controlled with your blood pressure medications. But again, that's not a contraindication. These medications for the erections, the ICI, should lower your blood pressure, but it doesn't really do that to any major extent. It mainly just stays in the penis. So that's not an issue. you can take your blood pressure medicines and do the penile injections. Sure, yeah, these are our two offices in Long Island. We're in Suffolk County. You've got the phone number there, I'm assuming, on the next slide.
Slide here. So
Yeah, perfect. Yeah, so that's our phone number, and then the website that has a lot of men's health information as well.
there will be more resources in the Resource Center on menmd.com. You can visit this page to view instructional videos, guides, expert articles, and more. If you still have a question and you'd like to follow up with someone, you can call MenMD at 857-233-5837 or log into the MenMD portal to schedule an appointment with a personal health assistant. And if you're interested in any of the injection accessories or devices that we talked about tonight on the call, you can purchase these by going to menmd.com.
If you found this video helpful and want to stay in the loop with our growing men's health community, be sure to subscribe to our channel and click the bell to be notified when new content is available. Your support makes it easier for other men like you to find these helpful resources. Thanks again for watching. We hope to see you again.